Okay, so remember, in the most basic sense, the brain is trying to take information about stimuli in the environment and figure out whether it's bad or good, and then either go to it or away from it. So here the killer whale sees the seal, right? The seal sees the killer whale. For the killer whale, this is a good thing. He's going to go towards it. For the seal, this is a bad thing. He's going to go away from it. And so this type of behavior requires both connections to the environment through the sensory system, as well as the ability to interact with the environment through the motor system. And this requires some connection between the central nervous system and the peripheral nervous system. And for many motor outputs, this happens in the spinal cord. Altogether, there are 31 spinal nerves. There are 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. That's him out there all by himself. Now, where along the spine do the spinal nerves exit? So you should know that C1 through C7 exit above the corresponding vertebra, while the remaining C8 through S4 exit below. One problem that happens quite frequently in the vertebral column is disc herniation. So vertebral disc herniation is most common at which vertebra? It's most common between L5 and S1, and this usually results in paresthesias and motor deficits along the area of the distribution of the nerve. In adults, the spinal cord ends around L1, L2. Therefore, a lumbar puncture is generally performed between L3 and L5 to prevent harming the spinal cord. A nice mnemonic is, to keep the cord alive, keep the needle between L3 and L5. If a patient comes in with a severe headache and nuchal rigidity, a lumbar puncture would be highly considered. And what would you expect to find? So the severe headache, especially coupled with nuchal rigidity, are very common symptoms of bacterial meningitis. So if you did a lumbar puncture, there would be an elevated opening pressure. You'd have cloudy CSF. And the reason that the CSF would be cloudy is because you'd have white blood cells, red blood cells, and bacteria, right? All the hallmarks of inflammation and an infection. In the next fact, we are going to go over spinal tract anatomy and function in detail. But here I just want to orient you to one motor tract and 2 sensory tracts that you need to know. The motor tract is called the lateral corticospinal tract, and it's shown here in yellow. It mediates voluntary movement of the arms as well as the legs. The dorsal column medium lemniscus is one of 2 sensory pathways. It mediates pressure, vibration, touch, and proprioception. You can see that here. This is the dorsal column part of the dorsal column medial lemniscus tract. It turns into the medial lemniscus once you get into the brainstem. Now the second sensory pathway is the spinothalamic tract, and you can see that here in blue. Spinothalamic tract mediates pain and temperature. Now note that the representation of innervation to and from the legs and arms are spatially organized. If we superimpose this stick figure to show that representation, you can see that the legs are lateral in the lateral corticospinal tract and the spinothalamic tract, but they are medial in the dorsal column. Now we'll dive into the details about these tracts. The dorsal column medial lemniscus, which we mentioned deals with touch and vibration, has primary sensory neurons that are part of the dorsal root ganglia. These neurons travel ipsilaterally to the medulla, where they synapse in the nucleus cuneatus for pathways from the upper body, or the nucleus gracilis for pathways from the lower body. So that's your synapse there. There's then a second neuron that crosses to the contralateral side and ascends to the thalamus, where it synapses with a third neuron that will then take the information to the somatosensory cortex. The spinothalamic tract has cell bodies of the sensory neurons located in the dorsal root ganglia as well. The spinothalamic tract is known as the pain and temperature pathway. So what is a unique element of this pathway in comparison to the 2 others that we will discuss? Well, Although this pathway has its primary sensory neuron in the dorsal root ganglia as well, once this neuron enters into the spinal column, it synapses immediately and then crosses through the anterior commissure to the contralateral side and then ascends to the thalamus where it will synapse again, and then that information will go to the primary somatosensory cortex. And so with the spinothalamic tract, you have an immediate crossing of the information to the contralateral side, then ascending, whereas in the other tract, the dorsal column medial lemniscus pathway, the information ascends ipsilaterally, crosses in the medulla, and then goes to the somatosensory cortex. The last of the three major tracts is the lateral corticospinal tract. This is the descending motor tract. The neurons originate in the primary motor cortex. They decussate or cross in the medullary pyramids and then descend down the spinal cord. The upper motor neurons synapse in the ventral horn of the spinal cord, and the lower motor neurons exit through the ventral root to innervate muscles. Each cerebral hemisphere controls the contralateral body because of this pyramidal decussation. So although this section is a bit fact-heavy, it will be critical to understanding questions related to spinal cord lesions as well as certain types of strokes. It's worth spending the time to solidify this information so that you won't have to remember all of the spinal cord lesions by rote memorization, but rather can take your knowledge of the anatomy and use that to answer questions. Alright everybody, it is time for a flash quiz. At what vertebral level are lumbar punctures performed? Lumbar puncture is generally performed between L3 and L5 to prevent harming the spinal cord. Remember the mnemonic: to keep the spinal cord alive, go between L3 and L5. The motor neuron signs are critical in helping you localize a neurological lesion. Upper motor neuron lesions are problems somewhere in the cortex or in the spinal cord. There are some key features of upper motor neuron lesions. They are hyperreflexia, a positive Babinski sign, Hoffman reflexes, and increased tone and spasticity. Lower motor neuron lesions are problems anywhere from the neuron exiting through the ventral root out to the neuromuscular junction. This is my super bad drawing of a muscle. The characteristics of lower motor neuron lesions include muscle atrophy, fasciculations, decreased tone and reflexes. Both upper and lower motor neuron lesions present with weakness. However, there's a helpful way to be able to distinguish between the two. One thing that works for me is remembering that with upper motor neuron lesions, the signs go up, right? Upper motor neuron, the signs go up. And by up, I mean you have increased reflexes, you have increased tone, you have upgoing toes, as is seen in the Babinski reflex. However, with lower motor neuron lesions, you guessed it, the signs go down, right? Lower, they go down. And by that I mean they have decreased reflexes, decreased tone, and they also have decreased muscle mass. Lesions to different regions of the spinal cord can produce different symptoms, and being familiar with these can help you determine the location of the lesion. We are going to cover all of the ones listed here, paying special attention to the high-yield topics. Some of these we will deal with in much more detail in later sections. Again, as with most of neurology, it's like real estate. It's all about location, location, location. Let's begin with polio. Polio is caused by the polio virus, right? A model of that is seen here. It is transmitted by the fecal-oral route. That's something that you should definitely remember. It was endemic in the past, but it is now largely eradicated thanks to the polio vaccine. Do you remember the two types of polio vaccines and the differences between them? So, you have the Salk vaccine, which is simply inactivated poliovirus that comes from 3 different strains. This is used now in the USA. But you also have the Sabin vaccine. This is a live attenuated vaccine, meaning that the poliovirus is able to infect and replicate in the gut, but has its neurological affinity removed. In microbiology, you learn that vaccines can either be live and attenuated or killed, and this is a great example of this. It would be worth reviewing the differences between live and killed viruses and when one type of virus may be better to use over another. For example, if you're attempting to elicit a cell-mediated response, a live attenuated virus would be better than an inactivated or killed virus. Early symptoms of poliomyelitis include fever, fatigue, headache, vomiting, stiffness in the neck, and pain in the limbs. 1 in 200 cases leads to CNS involvement, causing destruction of the ventral horn. This will usually lead to irreversible flaccid paralysis, which primarily affects the legs. Death can result if the diaphragm becomes involved. Next, we have spinal muscular atrophy, also known as Wernicke-Hoffmann disease. This affects the same area as poliovirus, the ventral horns. It leads to a flaccid paralysis, and you might also see tongue fasciculations. It is an autosomal recessive disease, so what is the chance that a child born to heterozygous parents will get the disease? Okay, so let's just work this out. How about we use H's for Hoffman? We're just going to do our Punnett square, remind you of some simple Mendelian genetics. Right, so the big H is going to be the dominant, and the small h is going to be the recessive gene. And for you to actually have the symptoms of this disease, you have to have both copies of the recessive gene. So when we fill in our Punnett square, we see that 1 out of 4, or 25% chance that future progeny will inherit the disease. It is both the most common and the most aggressive form of spinal muscular atrophy, and death usually occurs before the child turns 1 year old. We will discuss multiple sclerosis in detail during the pathology section. However, here's a good time to focus on how MS damages the spinal cord. Damage usually occurs in the cervical region of the cord and results in demyelination of the white matter tracts. In this case, it is interrupting information from which 2 tracts shown here. The answer here is the dorsal column and the spinothalamic tract. Lastly, we'll mention this again, but you should know this. This is the triad of symptoms to look for in MS, and those are scanning speech, intention tremor, and nystagmus. Sin. We'll get back to that mnemonic though. Amyotrophic lateral sclerosis is classically described as a combined lower motor neuron and upper motor neuron deficit with normal cognitive and sensory function. This is extremely frustrating because as the patient slowly loses function of the motor system, they are fully aware of what is happening. The disease usually occurs in middle-aged men. It is thought to be caused by a defect in superoxide dismutase 1. Do you know what the function of this protein is? Well, it's involved in degrading free radicals. This type of information is not often tested, but it's really helpful to know because you may get a question about ALS or amyotrophic lateral sclerosis where the answer choice is asking you for the mutated protein, and instead of giving you the actual name of the protein, such as superoxide dismutase 1, they might give you the function of the protein, and you'd have to remember the function that's applicable for that protein in order to answer the question correctly. ALS is a progressive illness with death ensuing once the respiratory muscles become paralyzed. There's essentially no treatment available. However, riluzole is one drug that has been proven to lengthen survival in ALS by about 6 months. You may have heard about ALS before medical school, and that's because there are various fundraising events that occur on television. It was made famous by Yankee baseball player Lou Gehrig and is commonly referred to as Lou Gehrig's disease. One area of excitement for possible future therapy is the development of ribozymes. And ribozymes are RNA that have functions similar to enzymes, and they would be able to degrade mutant superoxide dismutase mRNA before it's translated into protein. The anterior spinal artery above the T8 level is a watershed area, and as a result, it is susceptible to occlusion that leads to detrimental effects. Now, I mentioned specifically above the T8 level because below the T8 level, the artery of Adamkowitz provides collateral blood supply to the anterior spinal artery. During an occlusion of the spinal artery, you will usually spare the dorsal column as well as the Lessor tract. So in this case, what type of sensation should be spared? Yep, touch and proprioception. and this is because these are the sensations carried by the dorsal column. By the same token, you do not spare the spinothalamic tract, and so you should get loss of pain and temperature, and you should also get weakness due to damage of the motor tract. Next, we will talk about tabes dorsalis. This is a sequela of tertiary syphilis, and it is often tested, so make sure you know this. Syphilis in general is a high-yield topic for some reason. The board writers love syphilis. Who knew? Now, this condition can be thought of as the opposite of anterior spinal artery occlusion, as you get degeneration of the dorsal columns and sparing of everything else. So, given this information, what can you predict will be the impairment? Well, of course, patients will have impaired vibration and position sense. Those are the senses carried by the dorsal column. Other findings that you might notice with tertiary syphilis includes Charcot joints, neuropathic pain, and Argyll-Robinson pupils. These pupils are said to accommodate but not react to light, and this is often referred to as prostitute's pupil. If you can't figure out why, maybe that's actually a good thing. So, moving on. Unfortunately, the damage caused by tabes dorsalis cannot be reversed, and if left untreated, it can lead to paralysis, dementia, and blindness. To prevent this effect, what would you have treated this patient with during an earlier stage of their disease? The treatment for syphilis is penicillin G. Any questions about syphilis should be easy points on exam day if you take the time to make sure you know each different stage and its pathophysiology and differential diagnosis. We spoke about syringomyelia in the embryology section of this chapter, so let's use this as an opportunity to review and solidify some information. Firstly, the syrinx expands to affect the anterior white commissure, which crosses here. So, what tract will this affect? Remember, as the spinothalamic tract crosses within the spinal cord instead of at the brainstem like the other tracts, it will be affected here. It's also important to realize that this is a bilateral deficit. Depending on how large the syrinx gets, other tracts can be affected too, so be aware of that. You should also know that this usually occurs in the context of a certain neurodevelopmental disorder. What is it? Well, that would be Arnold-Chiari malformations. Let's wrap up by talking about the fact that certain vitamin deficiencies can have very extreme effects on the nervous system. Here we see that vitamin B12 or vitamin E can lead to degeneration of the corticospinal tract, the dorsal column, and the spinocerebellar tract. This leads to a number of symptoms that you could probably guess: gait ataxia, hyperreflexia, impaired position, and vibration. It's good to know that vitamin E deficiency is very rare and only occurs in very specific situations. For example, a patient with a fat metabolism disorder, right? Because vitamin E is one of your fat-soluble vitamins. What are the other ones? It's vitamin A, vitamin D, vitamin E, and vitamin K. Those are your fat-soluble vitamins. Vitamin B12 deficiency is actually more common and can occur due to simple malnutrition. Now here we've talked about one result of B12 deficiency. However, there's a much more common clinical result seen in these patients. What is it? Patients with a vitamin B12 deficiency will usually present with anemia. So one more question, what type of anemia would this be? B12 deficiency affects red blood cell production, and as a result, it would lead to a macrocytic anemia. And this is how you should study. Always make connections to other facts that you have learned. You've been integrated. Let's move on.